Assalamu alaikum and good morning. The topic of discussion today is non-muscle invasive bladder cancer disease management, and second one is specifically for intravesical BCG. As we have gone through the whole classification and definition of non-muscle invasive bladder cancer, just to refresh our memories, T1 and T1S, T1A, these are the this is specifically the only non-muscle invasive. All other categories are muscle invasive. Just to refresh memory. And there are three categories according to the risk. We have already gone through this. Low risk tumor is a primary solitary, less than 3 centimeter. Intermediate risk, all tumors which are no two adjacent categories. And high risk tumors which have any of the following: T1 tumor, high grade tumor or carcinoma in situ in the biopsy, and multiple recurrent more than 3 centimeter, or subgroup of highest risk tumor are classified into the high risk tumors of non-muscle invasive bladder cancer. This is just a flow chart we are going to discuss in the coming presentation. What we will be going through when we have a patient with non-muscle invasive bladder cancer. First of all, we will do the transvisceral resection of bladder tumor. If it is a muscle invasive, the whole management will be different. If it is non-muscle invasive or presumably low intermediate risk tumor with low previous recurrence rate, less than 1 recurrence per year, or EORTC recurrence score is less than 5, and while TRB there is no perforation, no extensive resection or no bleeding with clot, we will go for the single installation of chemotherapy. After seeing the cystoscopic view of the growth and resection of the complete growth. If there is suspicion that the growth might be the muscle invasive or high risk tumor, likely the sessile tumor, or frequently recurrent tumor, patient is also having the history of recurrence more than 1 per year, or there is a bladder perforation or bleeding with clots during the resection, then we can also give the chance of complete resection and pathological. We will wait for the pathological report. We will not give the immediate installation of chemotherapy. And when the pathological report will come, if there is incomplete resection or there is no muscle in the biopsy except for monofocal or T1 disease, we will go with the second TURB. We have a strong evidence within 2 to 6 weeks. And if the muscle invasive tumor, we will go through the other options. Macroscopically complete resections and specimen of TA, G1, grade 1, or even without muscle or in primary carcinoma in situ. We can stratify the patient in the risk group, high, low or intermediate, and then we follow the guidelines there. After the biopsy report is in our hand, we will see the three types: low risk tumor, which is solitary, less than 3 centimeter, T1, grade 1 or low grade. We will give the single installation of chemotherapy, and we will follow the patient continuously with cystoscopy every 3 months. If the cystoscopy is negative at 12 months, then we will go the yearly cystoscopy to see the visibility of growth. If the intermediate risk group primary or recurrent tumor without previous chemotherapy, we will give the intravesical BCG for 1 year, 6 weekly and 3 weekly, then 3, 6 or 12 months. We will discuss this schedule in coming slides. Or intravesical chemotherapy for up to 12 months. This is a strong level of evidence. If the recurrence tumor with previous chemotherapy, intravesical BCG for 1 year, the same schedule. In late recurrence of small superficial grade 1 low grade tumor, repeating intravesical chemotherapy. In all cases, the cystoscopy should be done at 3 months. If cystoscopy is negative at 3 and 6 month interval up to 5 years, then yearly follow up. If the tumor is high risk after the biopsy report, the recurrence rate is high or more than 3 centimeter. The highest risk tumor, T1 grade 3 or carcinoma in situ in the second TURB sample, or carcinoma in situ in the prostatic urethra, or there are multifocal tumor, multiple level of the urethra involvement is there, then we have two options. We will explain the risk of radical cystectomy or not. Intravesical BCG we will give for 3 years. There are two data suggesting about two things, or one yearly intravesical BCG or for 3-year intravesical BCG. Cystoscopy and cytology, urine cytology at 3 months. If the cystoscopy and cytology is negative, every 3 months for 2 years, every 6 months, and then after 5 years, If there is nothing on the concurrent cystoscopies and cytologies, we will give the yearly follow-up after 5 years. If the patient is having the papillary recurrence, the tumor is about of the papillary type and it is bleeding, and considering the specificities of patient like age and comorbidities and other preferences, we will first think to fulgurate the tumor, and then we will follow cystoscopy with chemotherapy, intravesical BCG. And if the large or non-papillary recurrence is there, then we will do the transurethral resection of growth and biopsies from abnormal looking mucosa, and bladder random biopsies if indicated, if the muscle is not included in the previous biopsies, and the biopsy from the prostatic urethra.
Yes. Now, you see, this is for everybody, whether the person is a junior person or a senior person in the team. What is more important? The more important thing in the whole process is the completeness of resection and the pathological report which has to be generated on that completeness of resection, and that is the tissue which you actually subject for interpretation by the histopathologist. Now, unless and until the completeness is there and the procedure is done in totality, the histopathologist is blinded. He will or she will only tell you whatever is in front of that person. If you somehow do something which is non-optimal or suboptimal, then the report will also be not representative of the patient. So, if you consider yourself as a very important person in the whole circuit, then it will be something which is meaningful. Otherwise, the treatment for the patient, a particular patient, will always be faulty. You will not have a good result out of whatever the treatment is. Maybe it's transurethral resection alone, if it is like PTA, or it is something which is intravesical therapy or chemotherapy. So your position as a urologist is very important, because you are the first person who is actually seeing inside the bladder and doing something for the patient. What we are doing at the moment in the last, say, for the last three months or so, we want to make something of a discipline, create a discipline within the whole process of TURBT. And what we do now, and this is something for everybody to understand, if a person comes to you for the very first time and this is the first cystoscopy that you are doing, nobody is giving you the impression whether this is something which is muscle invasive or non-muscle invasive. You will always have that impression if you have got something which is a radiological or clinical staging, meaning to say some CT scan in front of you, or if you do biopsy for the first hand, then the report will come whether it is muscle invasive or non-muscle invasive. So, when you do first cystoscopy, you will always have that impression that this is a low volume disease or a high volume disease, whether the whole bladder is occupying the, growth is occupying the whole bladder, or the bladder has got only a single unifocal lesion. So these are the kind of impressions that you can have whenever you see through the telescope, through the cystoscope inside the bladder. But again, you wait for a little while, maybe a week or so. If the report comes that this is something which is superficial, which is non-muscle invasive, you always do a second cystoscopy. That we want to make a sort of a routine practice, maybe in a few months to come. And I'll give you the report personally after December 31st, 2020, that now what we have got in the last 3 months in terms of second look cystoscopy. Now, second look cystoscopy should not be something which is at the mercy of somebody who is doing it. For instance, it has to be something which must be a must. It's not something which is an optional. It is something which has to be done. The reason being, if this is a superficial bladder growth and if you do a second cystoscopy and take random biopsies, you might hit something which is like CIS. If this is CIS, then the treatment changes altogether. If there is something which is like upstage or upgrade, both the news are very important. Both the news will actually guide your further future treatment on a separate scale. So you see, your second look cystoscopy will always be of benefit if the first cystoscopy is superficial or non-muscle invasive bladder growth, bladder carcinoma. But if it is like muscle invasive in the first instance, then there might not be, say, a value of a second cystoscopy. But because the definition that you want to have is already there, there is nothing which is beyond muscle invasion. If it is muscle invasion, then it is muscle invasion in the second cystoscopy also. Maybe your histopathologist or your radiation oncologist or your medical oncologist will say that they want a complete resection or a radical TURBT. Then you act upon it. Otherwise, the definition is very clear. So, I think we have to tackle this subject on a different level, maybe in very near future, in a month's time.
These are the general recommendations according to the guidelines. If the patient is smoker, then counsel smoker with confirmed non-muscle invasive bladder cancer to stop the smoking. And the second one, the type of further therapy after TURB should be based on the risk group shown in the table. It will be the individualized patient specification. In patient with tumor presumed to be low risk and in those presumed to be intermediate risk with previous low recurrence rate, less than 1 recurrence per year, or expected EORTC recurrence score is less than 5, one immediate post-TURP installation of chemotherapy is recommended. In patient with intermediate risk tumor with or without immediate installation, 1 year full dose of BCG treatment induction plus 3 weekly installation at 3, 6 and 12 months. Or installation of chemotherapy, the optimal schedule is known and we will discuss in coming slides. For a maximum 1 year is recommended. The final choice should reflect the individual patient's risk of recurrence and progression as well as the efficacy and side effect of each treatment modality. And in patient with high risk tumors, full dose intravesical BCG for 1 to 3 years, induction plus 3 weekly installation at 3, 6, 12, 18, 24, 30 and 36 months is indicated. The additional beneficial effect of the second and third year of maintenance should be weighted against its added costs, side effect, problems connected with the BCG shortage and other agents of chemotherapy. Offer transurethral resection of the prostate followed by the intravesical installation of BCG to patient with carcinoma in situ in the epithelial lining of prostatic urethra. And discuss immediate radical cystectomy with patient at the high risk of tumor progression. And offer radical cystectomy to patient with BCG unresponsive tumors and offer patient with BCG unresponsive tumors who are not candidate of radical cystectomy due to other comorbidities. Preservation strategies like intravesical chemo and microwave induced hyperthermia, electro-EMDA chemotherapy, intravesical or systemic immunotherapy or other clinical trials. It has been confirmed that the smoking increases the risk of tumor recurrence and progression. It is a level 3 evidence. While it is still controversial whether smoking cessation in bladder cancer will favorably influence the outcome of bladder cancer treatment, patients should be counseled to stop smoking due to the general risks connected with the tobacco smoking. In patients with tumor presumed to be the low risk and presumed to the intermediate risk and EORTC score is less than 5, immediate installation of chemotherapy within 24 hours after TURP. There are 4 large meta-analyses. They have comprised of about 1,000 to 3,000 patients. Consistently showed that after TURP, single installation significantly reduces the recurrence rate compared to the TURP alone. And the other patient who is having intermediate risk, 1 year full dose of BCG treatment plus induction chemotherapy. The final choice reflect the individual's patient risk criteria. There are 5 meta-analyses. They have confirmed that the BCG after TURB is superior to TURB alone and TURB plus chemotherapy. This is showing the superiority of BCG, and these meta-analyses are the researchers are conducting by studying the different control trials to see the superiority of the intravesical immuno or chemotherapy. There are 3 randomized control trials of intermediate and high risk tumors. They have compared the BCG with apirubicin and interferon, MMC or apirubicin alone, and confirmed the superiority of the BCG for prevention of tumor recurrence. And BCG maintenance dosage show that 32% reduction in the risk of recurrence for BCG compared to the mitomycin, but a 28% increase in the risk of recurrence for patients treated with BCG in the trials without maintenance. Only the induction and follow-up is given. There are two meta-analyses that have demonstrated that BCG therapy delays and potentially lowers the risk of tumor progression. It is the only therapy which lowers the risk of progression. All other chemotherapy, they lower the risk of recurrence. A randomized controlled trial with long-term follow-up has demonstrated significantly fewer distant metastases and better overall and disease-specific survival in patients with BCG compared to epirubicin.
Can somebody tell us what do we mean by recurrence and progression? Sure. What do you understand by these two very commonly used?
By recurrence we mean that initially it was diagnosed case, and on follow-up cystoscopies we didn't find anything like any growth or anything like this. Even if we take random biopsy or anything like this, which is even recommended nowadays. So, and by progression we mean there was a growth, and we were managing him with these things like intravesical BCG or things like this, and it was not responsive. It was further increasing in size, or the disease or maybe we find something else like distant metastasis or something like this. This is the progression of the disease.
Yes. The person who has raised the hand, I don't agree with you, but I must have the answer from somebody else.
By recurrence we means that initially, for an example, a patient presented to us and we did a cystoscopy and TRBT. It was, for example, TA low grade or T1 low grade. Then in next cystoscopy, we could not appreciate any growth. But in subsequent cystoscopies, we again found a tumor recurrence, but of the same grade. It has not progressed to a further higher grade. But by progression, it means that initially, for example, the patient was TA or T1 low grade. But in subsequent cystoscopies, the tumor had upgraded to further higher grade. It had either become muscle invasive or the grade has progressed from low grade to higher grade. That means progression.
If you give chemotherapy or immune therapy, if the initial response is that after a check cystoscopy you have not find any tumor, initially that tumor responded to that therapy. But after a subsequent cycles of chemotherapy and cystoscopy, you again find a disease. That is, I think, a recurrence on chemotherapy or immune therapy. But if the disease progress initially, suppose you give BCG and do a cystoscopy at 3 months, the disease progress initially, that is a progression.
You get the answer? Sure. So do you feel that there is some difference between your answer and their answers? So whenever we say, no, in recurrence there is a difference. For instance, if there is a disease and the disease has been eradicated and it has come again, then that is known as recurrence. No. So the second thing is the progression. Whenever we say progression, it means progression in terms of grade, or in terms of maybe it is stage progression. So in terms of stage, so you have one step and then you move on to the other step, then this is progress. This is progression.
I need one clarification here. As Aisha was mentioning here, if we, like for instance, we are taking it as a PTA disease, and it was patient was disease free, and on subsequent cystoscopy we found it's a PT1 disease. So there is a progression.
This is progression.
And in other instance, if the patient was having PTA disease and he was disease free, and now it was initially PT1 disease, and we are treating him with intravesical BCG or chemotherapy, and it was responsive initially, but later on become unresponsive, or the growth further increasing, or the number of the growth increases on risk stratification from intermediate to high risk. So what we call it? Is the progression?
It is progression. You see, progression is either in the way of stage or in the way of grade. So it's a grade progression or a stage progression. But recurrence means that there is something which was there, but now it is not there. It has come after, say, 1 year. It has recurred, came again. So this is called recurrence.
And the guidelines said that offer a transurethral resection of prostate followed by the intravesical BCG to the patient with carcinoma in situ in the apical lining of prostatic urethra. When we do cystoscopy in the suspected case or the proven case of bladder growth, we will also take the biopsy in prostatic urethra, like we were discussing in the previous presentations. In the prostate, the carcinoma in situ might be present only in the epithelial lining of prostate urethra or in the prostatic ducts. In these situations, should be distinguished from the tumor invasion into the prostatic stroma. If the tumor is invading the prostatic stroma, it will be the T4 is a disease, and for which the immediate radical cystoprostatectomy is mandatory. But if there is a carcinoma in situ in the epithelial lining of prostatic urethra, they can be treated with intravesical BCG, and transurethral resection of prostate can improve the contact of BCG with the prostatic urethra. However, the potential spread of carcinoma in situ has to be considered, and no suprapubic trocar placed catheter should be used in this type of presentation of disease.
Now you see, whenever we and this is a common observation, you all have been observing it for many years in the past and now also, that we do check cystoscopies, and when we do check cystoscopies, we only check. That means we believe in our visual appreciation of what's happening. Now visual appreciation has got a very little value in the whole game, because unless and until you take something of a biopsy, whether it's a biopsy of the tissue or whether it is something like a cytology, meaning to say you take the fluid out of it, you take the whole, maybe whatever is contained in the bladder, you take it, centrifuge it, take the supernatant out, take the residue and look for ploidy. So if you have got that kind of combination of visual appreciation plus cytology, then it is okay. But if you combine visual appreciation with a random biopsy, then again it's okay. But if you believe in your own visual appreciation that yes, I have done check cystoscopy, there is no growth, it's a big news, it's a big statement. Sometimes there is something which is beyond your vision, and that has been proved by newer techniques that we are using for detection of tumor, for instance, the blue light cystoscopy and other things. So the science has moved, and the science has moved in a very positive direction. So we have to move with science rather than believing in what we are seeing. Yes, for literature it is okay, believing is what you are seeing, but not in science. You have to prove evidences, present evidence.
And discuss the immediate radical cystectomy with the patient who are having the higher risk of tumor progression. There are several reasons to consider.
What is the question?
Yes, I have a question. Can you please move back? Sir, the last thing that is written, no suprapubic trocar placed catheter should be used. Now this thing, I in my residency, I've seen 3 patients who initially presented to us, and they had, for example, T8, T1 low grade. Then for some reason they went into detention, they presented in emergency somewhere in SIUT or outside, and because of difficulty in catheterization, suprapubic trocar was placed because the initial diagnosis they did not had it in their hand. Now the disease has progressed by a suprapubic placement or not. If it was, for example, TA low grade and now a suprapubic catheter is placed. So if the disease has progressed, because we say that T4B means it has spread to abdominal wall and the catheter is in the bladder, so shall those patients be offered immediate cystectomy, or what should be the management of these kind of patients?
Yes, you see, it depends upon the area in which you are working. Since we are a little fortunate in working in a country where, fortunate in the sense that we have got a lot of people with bladder carcinoma, we do have difficult kind of situations in which we have to go a little step, maybe taking a step in a direction of placing a trocar and a suprapubic catheter. That is not recommended. Yes, I am with it, but there are situations when you don't have any other option. When you don't have any other option, and whatever you are doing is your intention is correct. Your intention is to have something called provision of a passage for urine to come. But coming to your question specifically, that stage has changed or not, we have to prove it. We have to prove it by means of at least CT scan or MRI. Whether your placement or your violation of the rule has produced anything in terms of the stage progression or not, that has to be proved. Unless and until that is proven, you can't go on to have cystectomy straight away just by having a catheter inside. many of the instances, when I joined urology in early 1990s, it was something of a norm that you do bladder biopsy by open technique. Now there is nobody in this audience who has done it, or who even is in the process of thinking that they will do it in future, in their lifetime, because this is something which is now obsolete. But there is still a kind of a presence of such kind of a procedure. So if you want to take biopsy by an open technique, that means that you have to open up the bladder and take biopsy from maybe at the bladder neck or close to the trigone or in the posterior wall. The state changes according to this statement. So everything moves with the evidences, everything moves with something called development and scientific techniques. Now we have got more acumen available in junior people also of doing something with the cystoscope. So you can do wonders with the cystoscope now as compared to 25 years back, when it was something of say something which is not a routine kind of a procedure. So science has progressed. But coming back again to your question, you have to prove evidence. But you don't have to go straight away to another level of treatment.
There are several reasons to consider immediate radical cystectomy for selected patients with non-muscle invasive bladder cancer. The staging accuracy of T1 tumor by TURB is low, with 27 to 51% of patients being upstaged to muscle invasive tumor at radical cystectomy. There are level 3 evidence. Some patients with non-muscle invasive bladder cancer experiences disease progression to muscle invasive disease, and patients who experience disease progression to muscle invasive stage have a worse prognosis than those who present with primary muscle invasive disease. The potential benefit of radical cystectomy must be weighted against its risk, morbidity and impact on the quality of life, and discussed with patients in a shared decision-making process. It is reasonable to propose immediate radical cystectomy in those patients with non-muscle invasive bladder cancer who are at highest risk of disease progression. There are failure of intravesical therapy. Patients can benefit from BCG installation. Prior intravesical chemotherapy has no impact on the effect of BCG installation. And the recurrence and failure after intravesical BCG immunotherapy. These are the types of about what is the failure of intravesical chemotherapy. Several categories of BCG failures that are broadly defined as the disease occurring following therapy have been proposed. These are the categories of unsuccessful treatment with intravesical BCG. Sir was telling me there are two groups, responders and non-responders, and these are the non-responders: BCG refractory tumor present at 3 months after first course or first reinduction. What is BCG relapse? This is a recurrence of tumor after the completion of BCG maintenance dose. And what is BCG unresponsive? BCG refractory or T1TA high grade tumor BCG recurrence within 6 months of complete or adequate BCG exposure, or the development of carcinoma in situ within 12 months of complete adequate BCG exposure. What is BCG intolerance? Patient is having the severe side effect of the BCG installation.
What's the mode of action of BCG? Sharik.
It produces an inflammatory response there, then recruitment of lymphocytes and other cells that produce some cytokines that attack that tumor site and prevent further tumor growth, thus prevent the progression.
And what's the mode of action of mitomycin? Aisha.
So regarding BCG, the mode of therapy is divided into two ways. The first method is that it binds to the fibronectin in the bladder growth, and the second method is that it provokes an intense inflammatory response by producing cytokines, interleukins, and Th1 subtypes of the helper T cells. All of these help in combating the tumor response, help in combating or fighting against the tumor. That is the mode of action of BCG. In MMC, I don't remember exactly. I guess it's the same kind of inflammatory response, but I don't remember it exactly.
You see, you broadly classify something which is chemotherapeutic, something which is, say, anti-immunogenic. So, how do you classify these two kind of drugs? And maybe epirubicin and doxorubicin and other things. Yes, there was some at the back. So it is antimitotic in action. So it is something which is like a chemotherapy, right? So it is a chemotherapy which is done superficially. It's a superficial chemotherapeutic agent, and it acts locally. As regards this BCG, it is something which relates to immunity. It is pro or anti-inflammatory markers which are there, and there is a combat between the two, and in the end, there is a bystander effect for this kind of carcinoma, which is a superficial bladder tumor.
This is a tabulated form of different non-responding BCG groups, and they have said that offer radical therapy to the patient with BCG unresponsive tumors. A delay in radical cystectomy may lead to the decreased disease-specific survival, or in patient in whom radical cystectomy is performed before the progression to muscle-invasive bladder cancer, the 5-year survival rate was exceeded from to 80% levels. The evidence.
So what is BCGiosis? Sharik, close to exam.
BCG sepsis बता सकते
कैसे होता है?
BCGiosis.
BCGiosis. It is like antibiosis. So you all have got this kind of homework. Just look into it. It's a one-sentence homework. आगे चलिए.
Offer patients with BCG unresponsive tumors who are not candidate to radical cystectomy due to the other comorbidities and microwave-induced hyperthermia, EMDA, chemotherapy, intravesical systemic immunotherapy, preferably within the clinical trials. Device-assisted intravesical chemotherapy, there are three techniques. Microwave-induced hyperthermia. Promising data have been presented on enhancing the efficacy of MMC using microwave-induced hyperthermia in patients with high-risk tumor and hyperthermia intravesical chemotherapy. Different technologies which increases the temperature of instilled MMC are available. However, data about the efficacy is still lacking. And there is another EMDA, electromotive drug administration, and the efficacy of MMC using electromotive drug administration sequentially combined with BCG in patients with high-risk tumor has been demonstrated only in one small randomized control trial.
Just to add to this slide, one thing that might give you a positive sense out of it. Whenever since we are living in a third world country, so we don't have that kind of collaboration between the engineering or the electrical or electronics department and something which is a biological departments in a hospital. But we have got a little bit of experience with microwave energy and microwave hypothermia and thermotherapy. Our unit, SIUT, has got that kind of equipment in mid-1990s, and we did a few cases, around 300 cases of prostate, and we did something called microwave hypothermia for prostatic ablation. So we know the physics behind it. We know how does this thing act. We know how this technology can be used for the purpose of probably chemotherapy. So the understanding doesn't start at some level of, say, in the mid-level. It always starts something with the basics. So you must understand the basic physics, and then you move on to its application in medicine. And this is a very robust concept which is now coming up, and maybe in near future you will see it. For instance, the electromotive drug administration in medical oncology, as well as hypothermia for intravesical or say something which is within a cavity. So it is basically an intracavitary sort of hyperthermia which increases the drug absorption as well as it increases the receptivity of the tissue for that kind of drug which is being there for exposure to the tissue. So maybe this is something of interest, or maybe it is not of an interest to you now, but it will be something which will be a routine practice in very near future.
Just to refresh the mind, the pictorial diagram we have discussed already. BCG, now the intravesical chemotherapy is a live attenuated form of Mycobacterium bovis. BCG is the most commonly used agent for intravesical therapy, and a number of other agents have been used, but most are inferior. Nothing has proved superiority than BCG. BCG, the mechanism of action, BCG triggers the variety of local immune responses that last for a number of months, which appear to correlate with its anti-tumor activity. Number it causes the induction of mononuclear cell infiltrates, and it increases the expression of interferon gamma, which increases the sensitivity of bladder tumor cells to BCG by activating the lymphokine activated killer cells and antigen presenting cells. It increases the urinary cytokine level, including IL-1, 2, 6, 12, and interferon gamma, tumor necrotic factor alpha, and tumor necrosis factor of apoptosis inducing ligand. Number 4, it directly suppresses the tumor growth in a dose-dependent fashion. Dosage and schedule induction regime of BCG is weekly for 6 weeks, followed by a period of 6 weeks where no BCG is given, generally starting 2 to 6 weeks after TURBT. Well, first we will do the TURBT, then wait for the 2 to 6 weeks to heal that mucosal damage, and then you will give the BCG for 6 weeks every week, and then you will wait for 6 weeks more when you are not giving any BCG. This is the induction regime. And each dose consists of a vial reconstituted cornered BCG, which is about 80 to 81 milligram, or 2 ml ampule of Tice BCG, which is 50 milligram, plus 50 ml of sterile saline injected into the bladder through a catheter and retained for 2 hours. हम देते कैसे हैं कि पेशेंट को, we will counsel the patient that he should have a decreased fluid intake previous to the instillation, so that he should have a decreased urine in the bladder. He should void before the instillation of chemotherapy. He should lie supine. We will pain drape the patient and insert the Nansen catheter. If there is a retained urine in the bladder, we will empty it by inserting the catheter. Then again wash the catheter or change the catheter. Then instill the chemotherapeutic agent after making its dose. And then we will advise the patient to change its posture on left lateral, right lateral, supine and prone position for 2 hours.
Now, I don't know whether these days you have gotten an opportunity of doing it yourself or not.
So we have given it.
You have given it?
Yes.
Right. So all of you, they are all exposed to this kind of practice or not? Most of them. Right. So there are two kinds of manufacturing units or organizations which are producing BCG. One is the Canard, which is here, written here, and the other one is Pasteur Mario. And there is a difference in both these BCG strains. But Pasteur Mario has just stopped producing it, and there is one BCG which is available all over the world, and that is because of their own monopoly. So we are at the mercy of only one company all over the world, and there is now shortage of BCG. So we are not having it these days with us also commonly. So, but the whole process of how it has to be instilled and how it has to be done has to be learned by all of us. And the reason being, for instance, if the person has got, because these are the people who are in the same age group as having those who are with enlarged prostate. So they have got problem with evacuation of the drug. They have got problem with the evacuation of urine also. Since you rely upon the bladder for elimination of the drug after 2 hours, so it is very important that you must see whether the person has got the ability of emptying the bladder completely. Otherwise, there will be a lot of exposure to the drug for a very long time, because if the urine stays in the bladder is exposed to not only urine but also this drug, and the drug will be there for many hours. So if there is something called an enlarged prostate, then the prostate has to be taken care of first. As a matter of rule, the distal pathology has to be taken care of first, and then you move on to the next step. Again, if there is a history of hematuria, recent hematuria, if the person is having blood and urine now, you can't do these kind of intravesical therapies, whether it is for with the MMC or whether it is with BCG. The reason being that it will be absorbed in more, say, quantity and concentration, which is not required, and then you will have BCGosis, right?
The efficacy of BCG, intrathecal BCG is the most efficacious agent. It delays the tumor progression to a more advanced stage and decreases the need of subsequent cystectomy. It improves the overall survival. It is considered the treatment of choice of patient with CIS. The long-term outcome following intrathecal BCG therapy for non-muscle invasive cancer has been shown that after 10-year follow-up, the progression-free survival rate was longer with patients who had received the BCG, and disease-specific survival also increased. But mitomycin is the most commonly used intrathecal chemotherapeutic agent. It is anti-tumor, antibiotic, alkylating agent that inhibits the DNA synthesis, and it is having the significant molecular weight. It is so weighty that it cannot mostly absorb into the blood. Mitomycin has an established role as a single intrathecal administration following the resection of low-risk tumor. Mitomycin has also been used as an adjuvant given as a multiple treatment following TURBT. Dosage optimized regime using a decreased volume in which 40 milligrams is instilled 20 cc syringe with fluid restriction to reduce urine volume and complete bladder emptying, and now along with the urine alkalization to stabilize the drug. And there is a single, we have gone through this. Alternative.
Just a word about mitomycin. If you want to instill mitomycin and you don't protect your hands as somebody who is a caregiver, it will be absorbed with an intact skin also. You must be very careful, and more so with ladies. They should not be exposed themselves with this kind of drug because of particular physiology. So it is absorbed with intact skin. It doesn't mean that your skin is bruised, then it will be absorbed. So you must take care of it whenever you want to take care of any patient. You must have double gloves, and then you play with this drug.
And we have didn't discuss the techniques of giving the other techniques, hypothermia or EMDA. What hypothermia does, it improves the transport and penetration of mitomycin into the bladder wall, and EMDA in conjunction with intrathecal mitomycin is believed to increase the transport of drug across the mucosal membrane. And toxicity, it is an alkylating agent that is minimally absorbed from the bladder into the systemic circulation. As a result, myelosuppression following the intrathecal use of this agent is uncommon. Other toxicities have been reported following intrathecal chemotherapy: self-limiting chemical cystitis, often rarely a shrunken or contracted bladder, and a rash primarily involving the palms, soles, and genitalia. This is a hypersensitivity reaction. And what are the other agents? Gemcitabine, epirubicin, interferon alpha, and thiopeta. Rarely used nowadays.
Okay. So maybe next week we'll complete the same thing. Right. Thank you very much.
Right.